Good afternoon, everyone, and welcome to our public forum on integrated care on July 24th of 2024. This is the first meeting of this year, and we are extremely excited that we are very close to the transition of behavioral health into managed behavioral health care. That will occur on April 1st of 2024, which is just days away at this point. Today, we really want to spend some time hearing from you and talking to you with respect to our service updates so that you have some sense of what's happening there. Also, our readiness review process, which is currently in process, and then we would look forward to hearing from you through public comment. We do want to spend a little bit of time talking with you about what kind of information will be helpful for beneficiaries and others in the community as we move forward, because we want to make sure that people have the information they need to ensure continuity of care of the individuals who are receiving service. So those are my opening remarks. I'm going to turn it to my partner, Melissa Bird, who is the Medicaid Director, for her remarks, and then to begin our discussion on beneficiary engagement and communication.
Thank you so much, Dr. Bazran. And Happy New Year, everyone. I echo Dr. Bazran's comments, and it's great to see you all here. And we are moving quickly towards that April 1st carbon date, which we're very excited about. We can go to the next slide. And so Dr. Bazran really kicked us off here, but what we wanted to do is pose a couple questions to start off the conversation. And if you, I'll read through each question in case you are not joining us virtually through WebEx and maybe through a phone. So a couple things. And when Dr. Bazran and I were speaking about this too, it is the way we were thinking about this, and certainly if others feel the same or differently, we'd like to hear that as well, is that from a carbon perspective about who is paying for the service, whether we're paying for it directly or the managed care entity or plan is paying for it directly, I don't know if that's the kind of information that's most important for folks that are using behavioral health services. I think it may be more along the lines of, do I get to keep my provider? Are the same providers available to me? So do I have choice? How do I connect with a provider? Does it change or is it something new? So that's really some of that kind of thinking of really coming from, I'm a user of the behavioral health system, and what does this mean for me when we say we're carving in? So some of the questions to kick us off are like, where can and should beneficiary outreach happen? What type of materials or media are most helpful? And maybe that might be from you as a community-based organization that interacts with Medicaid beneficiaries, in particular those who are using behavioral health services, or it might be you as a provider entity and you want to have information available for your staff and for patients who come through the door. And then what is the need to know information for beneficiaries and families as they anticipate the April 1st carbon? So with that, Dr. Bazran, I don't know if you want to add anything, but we can
No, I think that that's absolutely right, and we really want to hear from you around this. And so you can enter your thoughts either by writing in the chat, or you can raise your hand and we will call on you, because we want to make sure that certainly we provide the information that will be most helpful. I mean, we have ideas about what needs to happen, but we really want to hear from you. So, what are some of the questions that you think we should answer? And I know I saw representatives from ULS here, and I know they do have some comment. Any comments that people have?
Hi, this is Jacqueline from ULS. Is it okay to speak?
There you are. Hi, Jacqueline. I knew
Hi.
I knew you had
You know-
questions.
Well, I've said to you, already what I can say here too. But yeah, I think it's absolutely important that GBH and DHCF staff are out in the community and not just in these virtual meetings getting this information out. I think it's really important to go to places like day programs, drop-in centers. I don't know, DBH staff could even go out to CRFs, places where consumers who don't have, stable access to internet and these forums can receive this information. I think it's important for consumers to understand how to identify which MCO they're connected to and how to contact each MCO, and for them to understand that that is going to be the entity that is deciding what level and what type of services that they are going to now get. So those types of things.
Okay, thank you. And John from Prestige, your question is, are MCOs ready for the carve-in? We are currently, and you're going to hear a little bit about it later, in the process of MCO readiness reviews. It is a very formal process, and it will ensure that MCOs are ready, just as we have spent the past 2 years making sure that you as a provider are ready. And so what is the role of Access Helpline moving forward? And this is one of the issues that we will address in writing specifically, and I've talked certainly to my staff about that. And so first of all, if somebody calls Access Helpline, Access Helpline will definitely connect them to the right party so that they can get enrolled or they get an appropriate response to their question. We will no longer be enrolling people specifically like we are right now. Those responsibilities will transfer to the MCO, and so more to come. But I think, Sarah, that's a very key question that needs addressed.
This is John.
Yes, go ahead, John.
Right. Yeah. Good afternoon, Dr. Basron and Melissa. The question I have has to go kind of follow up with the question that was, the initial comment in terms of the outreach. So my understanding is that some of the beneficiaries have already been divided to all the MCOs. Is that correct or not?
Mm-hmm.
Right. So the reason why I'm saying that, because I know that some of the are reaching the consumer already regarding who will be that person for them already. So I'm not really sure if DBH or FK Finance have to go out and do another outreach regarding that, if the MC are already doing that already. So that's just my understanding. They're already doing that. So I don't know if it will be the same communication. Would that be different? What would that look like?
Okay, I heard two questions, and let me feed them back to you to make sure I got them right. One is, are most or many of the individuals who are receiving behavioral health care already connected to an MCO? That was
correct.
one of the questions. And so that's a question that, and I'll have Melissa respond to it. My answer would be yes. And then second one, question that you had was, so please state that again.
So the second question is that if the MC have already been assigned to this consumer, should DBH or FK Finance be the one outreaching to inform the consumer?
And then how will outreach occur?
Yeah.
Okay, so those are the two questions. So Melissa, do you want to weigh in on that?
Sure. Well, first, good afternoon, John. It's good to see you. Second, I think it's important to clarify that the majority of the individuals that providers are serving today are in a Medicaid managed care plan.
Right.
So that part is not new for individuals, right?
Mm-hmm.
It is what is going to be new for the provider is who's paying for that service. Mm-hmm. So instead of you billing us, DHCF, and getting paid, regardless of whether someone's in a managed care plan or not, that's the part that really changes. And that's a payment change that should be fairly, not seen or felt by the beneficiary. Okay, so that part, if I'm receiving care through Prestige for behavioral health now, I may be enrolled in a MERA group, and a MERA group, I have a relationship with them. They are coordinating my physical health care services. Maybe they step in on the assessment piece, but so that relationship already exists. What happens, starting in April, and let me step back, and I hope that our plans have already made those contacts with folks that are enrolled in their plans, regardless of Carvin or not. They should already have those connections. And it is typical in what we've done here in the past when we've had major programmatic changes, the last really being when we expanded the folks who are served through managed care back in 2020, is that it is important not only will beneficiaries hear from their managed care plans, but they're also going to hear from us, the government. So in this case, both Department of Behavioral Health and Department of Healthcare Finance, because, the plans are our vendors. They play a very important role. They definitely should have and make those connections with beneficiaries and district residents. But it's just as important. I believe it's just as important for district residents to hear about these changes and have the opportunity to ask questions or raise issues that they're experiencing with us as government officials, so that we can understand what's going on and make adjustments or follow-ups with the managed care plans as necessary. And then for outreach, I think this was to your second question. Well, I think I just spoke to both the questions, hopefully. So let me know if something's still outstanding.
Mm-hmm. Okay, and then Christy, the question you have about how do people enroll in ACT, we do plan to do workflows and share it both with the providers as well as the MCOs and so forth, so that those steps are clearly articulated and we're all on the same page. And so thank you for that question. And Mark, I see you have a whole variety of questions from the beneficiary's point of view, and so those are ones that we will certainly also address. Other questions that people might have?
So
this is very helpful, as I said, because we really want to make sure that we hear from you.
So the other question I have, if you don't mind, also kind of goes into the access line question as well, right? So in the past, up to now, we know that the consumer have the right to choose if they want to be with a specific provider, right? Yeah. So in a situation with the MCO, now let's say we have 10 patients as an example assigned to an MCO, let's say Mesta. So now this patient, now they decide on day number 5, they want to go to a different MCOs. So what would that look like, and what effect would that have on the provider also providing those care?
Well, first of all, John, please remember, for the first 18 months, all certified behavioral health providers will be a part of every single MCO. And so people will still have the same choice that they have right now. So that will not change for that first 18-month period. And beyond that, I can't give you a response. But for the first 18 months, nothing, there will be no difference in terms of the provider network. There will be none. How will agencies be notified when consumer transfer agencies, and what will be the process? Okay, that's a very good question, and thank you, and we will respond back to that. What do I do if I can't find the type of care that I need from my MCO? Sarah, can you talk a little bit more about what you mean? If it's not within the in our spa, or
is it the kind of question you think we need to anticipate from folks as we shift into the Carvin?
Yeah,
right.
That's kind of where I was going, Melissa.
I'm sorry, Sarah. You're so low, I can't hear you.
I've been having issues with some of my volume today, Dr. Bazran. I think can you hear me now? Is that
Uh-huh,
okay?
great, thank you.
Okay, sure. Yeah, I think it's anticipating that that could be a beneficiary question. Again, maybe that doesn't come up as much in the next 18 months.
Mhm.
As you just mentioned, things will be stable, but I could anticipate that may be a question, right? Or if someone says, well, my doctor has recommended this type of behavioral health service, I'm having a hard time finding that with the list I've been provided, or again, if things shift in terms of various networks over the course of time, I could imagine that that may be a beneficiary question.
Okay, thank you for that. And then this question, Melissa, I think is an MCO question. Is it safe to assume that each MCO will have different requirements? And are you talking about different requirements for enrollment or a different process or, you know?
I'll go ahead and start to respond, and then if we get further detail, we'll respond to that as well. We have some standards that are set from the district level, specific to behavioral health through DBH in their role as the state authority, and then sometimes through us in our role as the Medicaid agency and assuming authority for Medicaid services. When it comes down to each managed care plan, they may have a different process for asking for a prior authorization. They could have different processes for how you submit a claim, things like that. So yes, it is, it is definitely safe to assume that each MCO has different ways that they implement their operations and requirements.
Mm-hmm.
I
Okay.
think I can, I'll take the next question if I can.
The next question is from one is from Mark, and his point is, and I'm not going to read through it all, is that all of the current providers in our network may not go through the necessary and needed contracting or credentialing process, and therefore might not be available. And so saying that every provider that's currently in the plan may still be in the plan following the carve-in may or may not be the case. However, Mark, the reason we put that 18-month period in there was to give every single provider that's currently certified the opportunity to be in every plan. Now, each agency, you might make a personal choice, but that's really what we can do from the government level.
And then Ambrose, good afternoon. Your question, in addition to John's questions, can we assume that if the MCO or the managed care organization is currently listed as a secondary provider, that the managed care organization will be primary at the carve-in? I might need a little bit more detail. What I'll say is that the managed care plan is not the provider. The managed care plan is the plan. The prestige is the provider, the physician or the hospital is the actual provider. So with this changes for a Medicaid beneficiary, again, at the onset, their provider choice should not change. Who they may contact for help with care coordination, and I can't find a provider, and an individual will reach out to the managed care plan, which they may not do today since behavioral health is carved out. So I hope that helps a little bit. And if not, please just add more to the chat.
And the purpose of this really was to generate questions and not necessarily just answer every single question. We want to put things in writing, and so we really do appreciate it. And Mark, we will respond in writing to the what if and to the possibility that everybody might be in there and what the other options are. So thank you for that. And then in addition, Christy, I think that the challenge that you've outlined in terms of the transition between levels of care and the appeal rights and process for MCOs is something that we do want to also identify and write out. Okay, so please just continue to, oh, that's right, Marie. But please continue to put your questions in so that we can have those. And because this will be a part of our meeting record. And as we are doing Q&As and really working through the process, we want to make sure that all of your questions are addressed. Okay, so please continue to put them in there. And then if you think of something after the meeting, please send it to either Melissa or I so that we make sure that it gets in the mix.
Good afternoon, Dr. Bazwan and Director Byrd. So given that the MCOs are honoring prior authorization that are in place, how will we handle the CSW issue since there's no authorization during the bridge period?
I don't know the response to that right now, Marie, but I will find out.
Thank you.
Okay? I will find out.
Thank you.
Okay?
All right.
All right. Okay. Can we move to the next slide now? But please continue. These are good questions. Please put them in there so that we can respond in addition to the things that we've already identified that we need to address. Okay. Elion Bell is going to provide some service updates.
Good afternoon, everyone. Thanks for the opportunity to give you an update on our latest implementation of the behavioral health integration rate study. We have a next batch of services being implemented on February 1st, which is next week. And we wanted to give you an idea of what some of those changes will be. We'll start with attachment and biobehavioral catch-up. This is a brand new service that I know we've discussed over the last year and a half implementing, and we're really excited about it. It's for kids ages 6 months to 2 years, and it gives disruptions in it's for disruptions in caregivers and or maltreatment. It involves sort of parenting classes. It's not exactly parenting classes, but it's 1 hour sessions weekly for 10 sessions. And so these are the procedure codes and modifiers that you will use to bill this and the rate that you'll be reimbursed for. You'll go to the next slide, please. Thank you so much. This is another service change that we're implementing. Of course, methadone is an existing service in our ACERS portfolio. Previously, providers were instructed to bill for administration and dosage separately. At this time, we've made 2 changes. We've combined the billing for administration and dosage. So for instance, for 1 day of both administration and dosage, you would just bill the H0020 with an HF, and you would get reimbursed for both of those without having to bill 2 separate codes. If the beneficiary, if it's clinically indicated for take home for that beneficiary, you can dispense 7 days, 14 days, 21 days, or 28 days. And then each of those different amounts of take home would be billed weekly. So the 7-day weekly rate would be $129.99. If it's clinically indicated that the beneficiary can take home 2 weeks worth of medication, then that would be H0020UB, and that's $259, and so on for 3 weeks and 4 weeks.
Mm-hmm.
So if you want to go to the next slide. And so we have 2 more rate methodology changes. So for this, we have 2 existing services. We've updated the rate and the methodology for Clubhouse and day rehab. This is something, again, that we've talked about over the last couple of years. For Clubhouse services, we have switched from a per diem methodology for Clubhouse to a per 15 minutes with a 6-hour max per day. And so the 15-minute increment is $11.90. And we just wanted to make sure that if a beneficiary isn't there for the minimum 3 hours, I believe it was before, to bill the per diem, we wanted to make sure that that providers could still get reimbursed for the time, and so this is the fix for that. And for day rehabilitation, it is a switch from a per diem to an hourly rate for, again, a maximum of 6 hours per day. You want to go to the next slide, please? Thank you so much.
I think there's a question for you back on the what constitutes a clubhouse or day rehab. If you can speak to that, to respond to that question.
What constitutes a clubhouse or a day rehab?
In terms of our certified. Go ahead.
Okay. I don't feel qualified to answer that. I can answer from a perspective of rate setting. Clubhouse, I believe, day rehab is more intensive than clubhouse. But I'm assuming that is not really the question. Maybe if you want to further clarify what you mean by what constitutes, whoever asked the question.
These are literally services that require certification by the provider. And so essentially, this is the rate that the providers who are certified as clubhouse, and I believe we only have one, or day rehab would receive.
Thank you, Dr. Bazran, for that assist. But that's exactly right. You have to be certified to provide this service. Any other questions before I move on?
In terms of getting certified to be a clubhouse, you can contact our Office of Accountability. I think Tia Jackson is on the line, and you can get that information. Go ahead. I'm sorry for interrupting.
Oh, no, thank you very much for interrupting. Okay. So we have 4 services where we did not implement a methodology change, and they're not new, but we did update the rate. We did look at the provider survey results, and we determined that the rate should be adjusted. So for transition planning, the rate has been adjusted up to $1,435.37, and that is per service. This is an intensive service for individuals transitioning out of an institutional setting, and so that really warrants the 8 hours or so worth of intensive services that are needed to bill this. And again, none of the specifications such as being certified as a transition planning provider or any of the other rules or regulations have changed. It's just simply a rate update. Additionally, we have what we have formerly called CBI, community-based intervention levels 1, 2, 3, and 4. We have updated those rates, and there's a slight change in name. So for CBI level 1, it's called multisystemic therapy, MST. I apologize for my dog in the background if you can hear her. And that's going to be H2033 at $62.28 and per 15-minute unit. And then we have what we formerly called CBI levels 2 and 3. That is per diem. It's not a per diem rate. I apologize for the misquote there. But it's the same rate for both CBI levels 2 and 3 for $59.95. The 4th service is FFT, which is formerly called CBI level 4. Again, using H2033, but with the modifier HU, and that is the least intensive of the 4 formerly CBI services, and the rate there, the new rate there will be $52.77. Any questions before we go on?
I think it's important for people to note that, community-based wraparound services, there is a per diem for that. That was one of the things that we were really looking for that. And then we have care coordination coming up also for intensive.
Absolutely, yeah. And let me just clarify that even though this description says community-based wraparound, this is not the intensive care coordinate. Right, exactly. This is not the intensive care coordination, high fidelity wraparound. Right. It is specifically CBI levels 2 and 3.
Leanne, this is Sarah Barkley Hoffman. I had a quick question on attachment and biobehavioral catch-up. Is there a code for both licensed and non-licensed folks? I thought I saw non-physician on both lines.
Let's go back to that slide, please. The answer is this is not a service that is provided by a physician. One more, I think, one more. Thank you so much. This is provided by an individual who has specialized training in attachment and biobehavioral catch-up, and there are supervision requirements and certification requirements associated with this, but is not provided by a physician. So both of them non-physician provider.
Okay, and what's the difference between these two?
Eliane, sorry to interrupt. This is Megan. I think the difference between these two modifiers, Sarah, is one is with the child present in the session, is one is without. So it's the same rate. It's just if the child is in the parenting session.
Okay.
And then to also answer your other question, it does not have to be a licensed clinician.
Great. Thank you both.
Mm-hmm.
Thanks, Megan. I appreciate that.
And the question is, will services and rates be incorporated into the DC Medicaid fee schedule? And yes, and the effective dates are listed for each of the services is listed on the slides.
Thank you, Dr. Bazran. Any other questions? I can't see the chat.
No, we're good. That
Okay.
was it.
Thank you. Okay, the next slide, please. And so these are a group of codes where we took a comprehensive look, and one of the requests that we heard, or one of the challenges we heard and tried to address with the rate study and integration, was that similar services across different provider types are reimbursed differently. And so we wanted to try and address that by doing a migration for some services from the HCPCS, the codes that begin with an H or a letter, over to CPT codes and evaluation and management codes. And so for one of the main staples of behavioral health treatment, counseling and therapy, that is what we did. At this time, our freestanding mental health clinic providers use these CPT codes to bill for counseling and therapy. And now we are saying that MHRS and ACERS providers will use the same codes. And we've also standardized the rate across the three provider types. So you can see that in the second row. This just kind of gives you a brief overview of what those CPT codes are and the associated rates. And those will be covered in a DHCF transmittal coming out soon. Additionally, the freestanding mental health clinics use brief screening and assessment to bill for very brief screenings of typically 5 to 10 minutes, but it could be more. You see here the CPT codes for those and the associated rates and the time limits associated. Any questions on that? Okay. Do we have the next slide? I think that might be the last one.
That's your last slide, yes.
Okay.
Hi, Elian. On the last slide, is there any limitation on participation on using the counseling/therapy set of codes for completion of assessment tools? Does that have to be billed as diagnostic assessment, or if people are updating a plan of care or completing a DLA 20 or APHIS, can those activities be included as part of the counseling therapy sessions and reimbursed under these codes?
It's my understanding that that's not the case, but I will tag team it over to some of the programmatic folks at DBH, if you could speak to that. And if not, I can take it back and give a more thorough answer.
Yeah, I think we just need to understand a little bit better how providers are supposed to seek reimbursement for completing those tasks that are not actually required for clinic services, but that are mandatory for DBH MHRS services. It doesn't look to me like there's a mechanism to be fully reimbursed for the time that it takes to do that work under this scheme.
Hi, everybody. It's Jennifer. Thank you, Mark, for your question. I do want to take a minute to address it because we've heard this feedback a couple of different places. So I think that one of the key clarifications around the tools and performing the tools and the functional assessments that we've identified in the district is that those are not necessarily procedures. So a lot of procedures are available to different provider types for different activities per our fee schedule. And it could be that for a certain procedure, a certain provider type is doing a brief screening assessment using one of those tools. It's possible you're using one of those tools as a therapeutic intervention or as part of a comprehensive assessment. But what the individual provider types will have to start doing is matching the procedure that they're providing, regardless of what that activity is, with what procedure code is most applicable to that activity and hopefully most financially advantageous for that activity. I hope that that clarifies that question. I know that we've heard it a couple of different ways, a couple of different times. Mark, please let me know if that's not what you were asking.
Well, it is what I was asking. I don't find the response particularly satisfying because there are restrictions on time for some of those services that cap out. And effectively, that means that providers are not being compensated if they need additional time. And so I'm concerned about longer session times or figuring out how we're supposed to seek reimbursement when completing all of the required elements under certification standards can't be done in the timelines indicated for those procedures.
Yeah, that's helpful. Let's revisit that with some specific examples at another time so that we can be sure we follow up in our next public forum.
Thank you.
Jennifer, you're up.
Thank you, Eliane. Thank you, Dr. Bazran. Hello, everyone. Great to see you all. Thanks for joining us again for our public forum. I'm very excited to talk to you about managed care readiness. I think many of you have interacted with me in my role as leading the Behavioral Health Integration Project for DHCF and with our DBH partners. But my day job, if there is such a thing, is actually supporting our contract administrator who is who oversees our contracts with our managed care plans related to behavioral health. So if a behavioral health integration project wasn't going on right now, this would be what I would be spending every minute of my time doing. And so I'm very excited to talk to you about some of it. Some of it will relate to questions that we received earlier in the discussion about the beneficiary engagement and communication plan. So we might be able to revisit those through some of these activities. Thank you to those of you who framed those questions from the beneficiary voice, since that's what we were hoping to get accomplished tonight. I really appreciate it. If there are any other questions about just general kind of managed care in the district, I'm hoping to check some of those boxes too in this section. You can go to the next slide. Okay, so what we do whenever we are engaging in kind of these large kind of or medium-sized changes to the covered benefits of our managed care contracts, we go through what's called a readiness process. And since this is my day job, I've actually been through one of these before. And so if that reassures any of you that it will be, managed in a similar fashion, we are pretty good at this. We do this pretty often at DHCF. We have, changes to our contracts that happen pretty often. We have reprocurements that happen pretty often. And so these readiness activities with our plans and even the plans that are actually in our market right now have been through readiness activities before. We just haven't done them related to these specific set of benefits. So the first phase of our readiness activities, or phase one, is actually a desktop review. This is where the experts at DHCF, in partnership with DBH and in partnership with all the feedback that we've collected from you over the course of the Behavioral Health Integration Project, is turned into a request for information, which we send to each of our plans. They have about 2 weeks to respond to every single one of those deliverables in writing that we submit to them in writing. And then the DHCF staff takes some time to review every single one of those documents to ensure that it's meeting the brief for enforcement of our contract, as well as any other priorities related to transitional events or vulnerabilities that we see in our system of care, any type of clinical practice standards or other priorities that we might have related to this integration. And we spend a lot of time doing very intimate reviews of those documents that our health plans spend a lot of time being thoughtful and producing for us. In phase 2, we do an on-site review where we kind of do a summation of some of the information that was exchanged in the RFI. Our plans have an opportunity to highlight and talk specifically about any things they're most proud of or that they've changed that are material to their operations. We have an opportunity to ask questions. We also have a chance to just meet our points of contact at the health plans, see their facility, maybe meet new staff. A lot of our health plans have been hiring new staff related to behavioral health. And so I'll be looking forward to meeting some of the new movers and shakers in the behavioral health world at the plans during our on-site review. In phase 3, we take all of that information and we synthesize it into a report that we send to CMS for approval. We like to communicate to CMS some of the things that we're doing in the district to try to bring all of these pieces together for behavioral health. So I want to pause for a minute and ask if there are any questions about the readiness process and review specifically that I just outlined.
Jennifer, I just wanted to add something to what you've said so that people know that members of the DBH staff will be participating fully in this whole process. Individuals with content knowledge in that one of the various specialty areas will be on site to do the review, and they will be working very closely with DHCF, so our feedback will be incorporated directly into this process.
That's right. Thank you, Dr. Bazran. You beat me to it, and that's a good segue into my next point. So I said before, and I do think I want to just pick up one point that I know was made earlier, but I think it bears repeating, is that the enrollees have been working with these plans already. What is changing about their interaction with the plans is that the covered benefits, which previously were not part of the plan's requirements for the enrollee, are changing to include the entirety of the behavioral health services in the district. So these plans are very well versed in the operations about how clients access their services. They have, support lines. They have care management teams. They perform prior authorizations. They do marketing and outreach. They have wellness centers. They do all these things for all their enrollees. All the folks that are getting dental services and cardiology and going to the hospital in the emergency room, all of those things are going to be very familiar. What we have done through this process in partnership with DBH and in partnership with you is taken a critical look at all of those key operations and all those key functional activities and really assessed one by one what about those operations and key activities need to either be adjusted for behavioral health, what about the behavioral health service utilizers needs to be factored into some of these processes, what are some of the things we want to improve, or what quality of care issues do we want to try to eradicate in this transition. And so it's really taking the things that we do as our basic operations within our managed care program and applying a lens of behavioral health to each and every one to ensure that we are addressing some of the questions and concerns that you all brought up earlier. So a lot of these things we're very used to them. We have those muscles in place. It's really applying the behavioral health lens that we've been able to do as part of this integration. Does anyone have any questions about our readiness activities and kind of the strategy that we've employed so far?
Jennifer, this is Atia. There's a question in the chat that I'm not sure you can see. It says, does readiness review include review of credentialed providers in the MCO network and testing of claims payment system for new providers?
Yes, thank you, Atia, and thank you, Tricia. So yes, one of the key things that our health plans have received from us is a claims file for their enrollees of all the services across the different providers that they've received for the past 2 years. This gives our plans a really good idea of what providers are being utilized, to what volume, what specialty services live with which providers, where beneficiaries are going for services, and what their kind of historical consumption of those services has been over the past 2 years. That's a great way for our plans to be reaching out to different providers that may have not been on their radar, to making sure that their networks are adequate to meet the needs that have already existed for those enrollees over the past 2 years. And so, yes, we definitely want to make sure that the network is adequate, and we are using claims history to do some of that validation. In terms of claims payment testing, we do have testing of claims as part of the onboarding activities that providers should be doing with the plans. If you have not been in contact with our health plans and you are a provider who wants to participate in the Medicaid Managed Care Program as of April 1, please reach out to our plans. Please reach out to me. I have learned from our plans that they are looking at the claims reconciliation, and they are looking at the updated provider list that DBH has provided. And there are some providers that they have not had contact with. Please be in contact with DHCF, and please be in contact with the plans if you are planning to serve beneficiaries that are enrolled with the plans on April 1. We're here to help you. We want to expedite that process as much as possible. It is in our plan's interest to get you in their network and to expedite that process as much as possible. So please let us know if you have not started or initiated those conversations yet. Claims testing will be part of that process.
Any further questions? I think that Mark Lavoda has another question. Is DHF with DBH making clear that network adequacy reviews only give credit to fully credentialed rendering providers and not just group level provider participation agreements or credential reviews pending? Jennifer.
Thank you, Mark. I think I know what you're asking, and I'm hoping yes. I think this is another really important clarification that we need to make. We often use provider to mean provider organizations, which are really large groups of individual providers. And since our behavioral health network of providers has been required to individually enroll in Medicaid effective July, when we say providers, and a lot of times when the plans say providers, they actually mean individual providers. And so if you are a group practice or a provider organization that is made up of lots of different providers, if they're licensed or they have particular credentials or certifications, they probably will need to go through a credentialing process. And if they want to practice individually in the district, they will need to go through a Medicaid enrollment process, and they will also need to be individually known to the health plans. This isn't something, that can be accomplished in a weekend. This is a multi-step, multi-layered process that takes a long time, requires lots of brokering of documentation. And, our plans really want to make sure that the provider network is capable of providing the services, that we are reimbursing you for. So it is a quality of care practice to ensure that providers go through these checks and balances to be sure that we have good actors in our network and that folks are capable of providing the services that we plan to pay you for. Mark, was that kind of the distinction you were hoping to make?
Well, it doesn't go quite as far as I was making it. I think you described the purposes that you hope credentialing helps you to achieve. I'm talking about the flip side of how many people are actually credentialed and limiting your network adequacy reviews to determine whether or not there are enough providers to only the people who have actually made it through credentialing. I'm concerned that there are both thousands of licensed providers and probably only a small fraction of them have so far completed credentialing. I'm concerned that we still haven't heard any plans for the thousands of unlicensed rendering providers in the DBH provider network. And I know that they're not necessarily going to go through credentialing, but I think we need to have some more understanding about our readiness to launch based on how many people the plans have known to them and are fully prepared to pay on day one.
Mm-hmm. Yes, and Mark, that assessment, the self-assessment and DHCF and DBH's assessment will be part of our formal readiness activities. So the plans have had kind of a ramp up period to grow their network and to panel who they need in order to have a complete and adequate network on April 1, and they will report that to us through our formal readiness activities with remediation if needed.
And Jennifer, another question from Christy. Has a final decision been made on non-licensed staff and credentialing? We're praying it won't be needed now that they have NPIs.
Does any provider on the line who has gone through their enrollment process with the managed care plans want to endeavor an answer to Christy's question? Does any plan who's on the line want to endeavor an answer to Christy's question?
We've been credentialed so far. I mean, we've enrolled with all the MCOs, but there's not clarity about what's going to be needed down the line. Like, is just a roster fine?
Okay, so we will get those conversations started. Thank you for bringing it up, Christy. We will formalize that in our readiness processes so that we are all on the same page. Another theme that came up
Jennifer?
One second. Another theme that came up earlier is for the desire to have standardization, and that is our desire to have standardization during our transition process. So if things are not clear, we will be sure that they are clear as part of our readiness activities.
Jennifer, this is Dr. Black. Can I ask a question? All right. I think I can speak to the process. My understanding and what we've been going through at MBI is that you have to contract with the providers, with the contractors. And once you finalize your contract, then you're ready to get your people credentialed with them. And we have started that process, and it's pretty extensive. And so, and I can tell you that we had set all of our credentialing staff to the providers a couple months ago, actually a little, probably about almost 2 months ago. And we're just hearing this week, right? And we heard last week on the who made it through, who there's had some concerns about, that we need to do something different. And we're all currently working through that list to send it back. Okay, so I want to say that it is not a tomorrow process. It's a extensive process. And my concern is that I feel like there might be some double messages that people might be hearing or misunderstanding, in that we're saying in one hand, all providers will be transitioned to the MCOs for the first 18 months and there won't be any changes. Are we saying that there's a partnership between the government and the providers, that if they don't do these processes, they're going to be transitioned anyway? How does that work? Because I'm concerned about continuity of care for our consumers, which I think Mark is getting to. Because what happens if we have consumers who, as you mentioned earlier, some providers have not even reached out to the MCO. And I don't understand, when we 43 business day away, okay, I did the math, that some people can get contracts and credentialing done to continue care for their people by April 1st.
Yeah, thank you so much for the feedback from your perspective. I think it's a really helpful point of view for some of the folks that have joined us this evening. I will say that, from the inception of the policy that we wanted the DBH certified providers who are willing and able to be part of the networks, that is not a promise. That is a requirement. So on the DBH certified provider side, it's a requirement that if you're a DBH certified provider, that you are interested and willing to participate in the managed care program in its entirety. That was something we wanted to make sure that there was equitability across plans and some standardization. And it's also a policy that cues to our health plans that it is our expectation that they are working with you. They are doing everything in their power and everything that they can staff and turn around as quickly as possible to get you all across the finish line in the provider network. But that policy is not a magic wand. Speaking it out loud does not make it true. It It is the summation of activities on the side of the providers and activities on the side of the health plans, so that providers are capable of providing a service on April 1 and submitting a claim. That will require activity on both parties' part. I hope that that clarifies what you are saying, Dr. Black. I think that's a very important point. Us saying it out loud does not mean that we are able to make claims go through if you have not arranged that process with the health plans for yourself by April 1.
And there was, I think John had a question, and then Patricia has a question in the chat that I'll share with you. John, do you still have your question? Do you want to unmute?
Yeah, the question I have, I think gonna answer is about those who are unlicensed, right? Because I know that the unlicensed one, Mary Head did mention that there's a requirement that everybody they had to be credentialed, while by other MCOs say they do not have to be credentialed. So that's, I think the question Christy was asking, as to kind of go with that decision. Have we made decision in terms of do they have to or they do not have to? If not, then we have to be on the same page on that. So I just want to clarify that question from Christy.
Yeah, that's good feedback, John. And I think that's feedback related to the broader question, which, Mark has raised and you have raised and Dr. Black has raised. So we will definitely get follow up on that. But that's good information to know that that's what you've experienced through this process.
And that Patricia's question is, will DHCF report out on readiness prior to go live? Are there benchmarks that, if not met, would delay go live? I can tell you the answer to the last question, but go right ahead.
So Trisha's pushing me a little bit past my pay grade. I know I said I'm the managed care contracting guru, but I will say that in a theoretical universe, it is possible for DHCF and DBH to deem the plans not fully ready. But what we usually do is, again, as kind of part of our standard processes and our standard practices, we can create corrective action plans. We can create some, remedies that can be turned around and with quick time frames in order to rectify that so that we don't affect our time frames. But technically, to your question, this is not a token activity. It is actually an assessment and an evaluation of whether our plans are ready to take on these benefits in the established timeline.
Mm-hmm. And there are no plans to delay this. That we've had 2 delays already. That's what I just responded to that, Marie. Other questions that people have?
I just wanted to make sure, Dr. Baswan, I've heard.
I know, and I was just trying to respond,
I've heard
Dr. Black.
So I just want to be clear.
That's right. And that's a good thing. Any other questions that people have?
Yes, Dr. Basran. Can I shift to questions about the assessment tools that are being used? We know that the DBH certified providers have specific assessment tools that are tied to specific ages and levels of care, and whether it's MHRS or SUD. I have heard in conversation with managed care plans different understandings and expectations about how they will make use of those assessments or whether they will make meaningful use of those assessments at all. And so I'd like to know if during this readiness review process, there's a discussion that's happening about how they will incorporate the results of the required assessments into their utilization management or utilization review requirements, and kind of more broadly, if there are requirements that are being put in place for those plans to develop specific clinical criteria for different levels of care or services. And, if that's the case, then how quickly those might be shared with providers so that we have an understanding of what criteria are being used to make service determinations.
Mm-hmm. And we'll follow up with that, Mark.
Yeah, so Mark, to your question, is that part of readiness? It is. So the plans will have to provide us with their policies and procedures for operationalizing, training, and effectuating the tools that are required by DHCF and DBH. So if we hear different messaging, or if you want to illuminate me on the messaging that you've heard, we can talk more about that.
Well, just generally, I think the question is how much do they have to weigh the assessment tools versus other information that they may have available to them? We know that they have claims data. We know that they have survey data. We know that they have, analytic tools that correlate people's behavioral health needs with their physical health and hospital utilization. How does that get weighed? Is there a standardized process as part of the exercise around standardizing things across the plans? Is there work being done to help provide some sort of consistency so that it's not 3 different sets of clinical criteria for each of the 3 plans? These are, really fundamental to how we all prepare for making this work moving forward. I don't even know if all of the managed care plans UMUR teams have received training on those tools that's been required from provider organizations. So just be really helpful to get some more information about the status of that part of the work.
Mm-hmm.
Thanks for raising that feedback, Mark.
Mm-hmm. And then Dr. Black put a question in: How will DBH or the MCOs manage the care of consumers for providers who have not finalized their contracts or credentialing with the MCOs? I think that's a good question, Marie. I have no quick response for you, but it's something that we'll address.
We'll say to that point, though, what we typically do we are implementing a new contract. We have a continuity of care period or transition period where we expect, even if the services will be rendered and honored, regardless of the contract status. That's to ensure that continuity of care, and I expect we will have the same for this process. And if you've recalled in the past, we usually issue a letter from DHCF, and I think it goes to all the plans. Or I think that's the way it works. I just can't remember off the top of my head. So we document that, we post it on our website and make it clear that providers can expect payment for services.
Okay, thank you for that, Melissa. Any other questions before we conclude and move to other public comment? Okay, so now it's an opportunity for us to hear comment from the public. Oh, I'm sorry. Reminder of bridge policies. Jennifer,
Yeah.
please move on.
No worries.
Mistake.
No worries. So we just wanted to remind folks about some of the bridge policies that had been in play. Mostly this is going to be refresher for many folks, but we have immortalized these into an information bulletin that will be published. And so for those of you that would be new information, we just wanted to put our slides in the presentation today and be sure you're aware. Many of these policies we referenced already this evening. So the first one being that all the DBH certified providers who wish to participate will be in network with the health plans as of April 1 for a period of no less than 18 months. We also plan to direct payment. Many of you have heard the term directed payment throughout the course of the behavioral health integration. What that means is that we will tell the health plans that they must pay no less than our established fee schedule for the first 18 months of the period that the providers contract with them. And thirdly, we talked a little bit about continuity of care and what will happen for PAs that span April 1. That care will continue through the end of the prior authorization or the course of treatment, and the individual will receive 1 additional episode of care at the same level of care for the same service. I think there were some questions earlier about community support related to this benefit. I don't want to invent additional work for us for services that do not require a PA. The benefits will be managed as written, but we won't be creating new PA processes for services that don't require a PA. This is for services that will actually have a prior authorization that must be in the system for claims to be paid, and what will happen to those PAs that span April 1, and then an additional term of PA for those same benefits to ensure continuity of care. We can go to the next slide. We've also heard folks reference our tools. We have several standardized tools that we have selected and will be implemented by our health plans. As I said earlier, this will be part of our formal readiness activities and implementing these tools at the plan, both for their staff to use internally for things like prior authorization requests or screening and assessment and appropriate levels of care, but also things they will collect and receive from providers related to quality of care management practices and clinical practice, as well as prior authorization. We can go to the next slide. Any other public comments that anyone would like to make at this time, either out loud or in the chat? So I heard, will DBH be giving the MCOs a list of the current plans? Yeah, so just to be clear, I know sometimes we can commingle things like treatment plans and prior authorizations. A lot of times in the management of these benefits at DBH, those things were one and the same. But we are actually talking about prior authorizations that must be in our billing system to allow claims to go through. Treatment plans are clinical documents that live with the providers, and those, those are documents for providers to use to ensure, care is occurring appropriately within your provider organization.
No, Jennifer, I understand that. Thank you for that clarity. What I'm asking, and we were discussing this as the DC Behavioral Health Association the other day with the MCOs, is that no one in this system wants thousands of care plans and authorizations to all start on April 1. So will DBH be giving a file to the MCOs with all the authorization spans, or is that going to be just better done by the individual organizations?
Yeah, so I think it is worth us following up on the way that that DBH has been managing the PAs during the gap period, but our system already has the PAs. We will be providing it to the health plans for what they need to know to operationalize the services on April 1. Okay, I see a comment from Mark. Does the comment about community support mean managed care plans are being instructed that there will be no authorization requirements for community support moving forward? Okay, thank you, Mark. Yes, we have previously stated that we will be reassessing the community support benefit around July. And so you can look forward to some possible changes or enhancements to that benefit that will also include our health plans. So they will have a few months during our initial phase of our integration to kind of see community support for themselves, get a better understanding of it so that we can all move forward together with full information around how we may want to make adjustments to that benefit.
Dr. Black and Mark Lavoda both have their hands up. I'll see if anybody else does.
My question was around continuity of care for our consumers and children and families. So I just wanted to make sure I heard you loud and clear, Jennifer. For clarity, so if a provider has a service that's expiring, let's say April 15, the MCOs have been per contract directed to provide another episode of care so that we do not have to seek an authorization 15 days into the transition.
That's correct. For services that require a prior authorization.
Okay, thank you. That is breathing messaging. Thank you. Appreciate that.
Mark?
Thanks. So there was a question or comment in the chat earlier that just got lost or disregarded. I think it was from John Smith about the MedSom benefit. There's been a change to the billing codes and which billing codes RNs and LPNs are allowed to use. And it's inconsistent with the current regulations. But also operationally, it will probably mean that MHRS providers that have been using nurses more extensively are not going to be able to maintain nursing staff. I think part of the solution might be some of the picking across multiple procedure codes and differentiating what kinds of services nurses are providing. But I haven't seen any documentation yet about how nurses are actually supposed to work in delivery of MedSom at this point. Is there any further guidance forthcoming about what role nurses are expected to play in MedSom moving forward? And is there further guidance forthcoming about the combination of different procedures that nurses will be allowed to bill under in a continuous time block, even if those are several different procedures with different billing codes?
Mark, I think we can take that back. If the group feels that nurses specifically are a provider of interest where we need to do a deeper dive, I think we can take all of our guidance to date and actually do a nursing specific billing forum or a public forum related to that particular provider type.
Yeah, I think especially after the updated guidance about how to interpret the November the 1st codes was released, there have been a lot of questions and there's a lot of concerns. So as quickly as we could get that kind of forum set up, I think it'd be a benefit for the whole system.
So I do see another community support question, and I just want to provide some guidance because I do hear everyone that is a priority. So for services that do not require prior authorization, providers provide them when they are medically necessary to an enrollee who is willing and interested and has them as part of their patient-centered treatment plan. We do have policies that it might have been a while since some of our providers, both individual providers or provider organizations, have not read or understood those policies in a little while. The way those policies are written is how our managed care plans will enforce them. So if your team's a little rusty on what the regulations around community support say, I would encourage you to go back and read them and ensure that new staff and quality staff and operations staff that you have on board are understanding what the parameters of them are. That being said, any other type of utilization of those services will be for the managed care organizations, teams, and utilization review teams to be analyzing just like they would for other services. If they feel that someone's use of those services might indicate the need for a higher level of care, that might be a piece of feedback that the plan provides you. If it's possible that someone's underutilizing services, that might be a piece of feedback that the plan provides you. But if a service is part of covered benefits and does not require an additional prior authorization or does not have any additional guardrails that are immortalized in policy, then those services are provided on an as-needed basis. I hope that clarifies the question. Dr. Freeman, is that your question? If you can answer verbally or in the chat.
And John,
Not exactly, because I know what the regulations say about CSP, and I understand what's been written and what's available to us. But there has been a lot of discussion about changing CSP and changing who will provide it, changing how it will be billed, changing what services can be provided by those people that are going to be providing it. And it sounds to me like that conversation has been pushed back to, or at least
July.
maybe the resolution of that conversation has been pushed back to July.
No, it's not even the resolution, David, is we are going to begin that discussion in July. Nothing will change at this point. We didn't want to have multiple things, more things changing during this transition process. So
Okay.
nothing is changing.
Thanks, Dr. Bassman.
In July, we will begin the process of talking about community support. We know it's a big deal, and we want to be intentional, and we want to be, really careful about, how that process works. And so that's when it will begin, in July.
Okay, so I guess what I'm hearing is that we will continue as we have been, following the regulations and everything else until there's a specific change July or after. And I guess what I'm hearing is that the MCOs will pay for that.
Yeah, David, because we're just going to begin our interactions with you. I mean, this is going to be a joint process. We're not going to sit in a room and simply change community support and then inform you of that. Okay? And so beginning in July, Melissa and I will begin those discussions with the provider network.
Okay, thanks, Dr. Basran.
Okay, Marie has a question. When an agency decides to close, DBH assistance supporting the consumers and seeking a new agency for continuity of care by seeking where there are vacancies. Will that still continue? That will no longer be our role. You may want to speak to that, Jennifer, from the MCO's perspective.
Yeah, the health plans are definitely intimately involved with when a provider is no longer part of their network. There is a formal notification process. There are transition processes in place. And especially if services are critical or for individuals that are highly vulnerable, there are policies and practices in place.
If I have to come in, can you hear me?
Thank you. I just want to make sure the consumer voice and their concerns are being addressed, and that we know where those things are gonna, who's gonna be responsible for those things that are so important to our system.
I agree with that, Marie. And I think that that's a part of, as we were talking about earlier, that's one of the things that we need to include in the materials that we put out for people in care and their families, as well as providers, so that everybody knows what happens.
Thank you.
Okay. I see no further questions in the chat. Jennifer?
This is Juanita. I had a question in the chat, Dr.
Hey,
Basran.
Juanita. I'm sorry, did I skip over you? It wasn't deliberate. I didn't do it on purpose. Let me go back. Go right ahead.
The questions about the gain eye. Oh wait,
Yes.
Juanita, you're on to say your own question. Go ahead. I'm sorry.
Okay. This was earlier when you had put up the various assessment tools,
Right.
and you had listed the gain eye. I am one of those people that would like to take the gain eye out back and shoot it. And so I'm wondering, is there still a window, or, to include a different assessment for adolescents with substance use disorders?
So Juanita, I heard Mark ask for some specific drill downs around kind of procedure code mapping and to the functional tools. And so could we add the thoughts and feelings about the functional tools to possibly that meeting, so we can hear a little bit where you feel like the tool is falling short, or why it's a challenge to incorporate into your practice? Could we include that item with that meeting?
Yes.
Okay. And also Dr. Sullivan is on, and that falls within her purview.
Sure, I would add, I think that it would be helpful to have that conversation, as Jennifer said, but we did select the gain eye just because it's the best practice right now. We know that there are some challenges around it. However, that was the tool that was selected and is part of the decision memo that went through a few months ago. But again, happy to have a conversation. And we can tag it on to the conversation that Jennifer mentioned around the other assessments and the procedural codes.
Okay, definitely, Dr. Sullivan. With respect to the gain eye, it may be a good practice, but it's a barrier to treatment. But we could talk about that later.
Yeah. Yeah, and we would really appreciate your feedback, because you're there with the young people. Okay. Are there any other comments, public comments, anything from the public? People who are receiving services, any comments you have, or any family members, other members of the public?
Hi, this is Dr. Mogimi. So I just had one additional question around the continuity of care, and I understand I think I'm pretty clear on the specialty care services that have authorizations in place that we'd be receiving, so that we would have a clear sort of beginning and end date around those. And since community support doesn't require prior authorization, they may not necessarily be on that list. But I know that if in situations where providers are needing an additional units past their allotted amount per treatment period, I guess I'm curious, how would the MCOs kind of know what that unit limit date is? You know, is that something that we would also be considering as a part of the continuity of care? Because if that, while there isn't sort of a prior authorization for most community support, I think in the manual there is a kind of indication that if folks need in excess of the treatment allotted amount, there would be a request.
That for justification,
Right,
correct.
right.
Yeah,
Okay,
we can talk at that level of technical detail, Dr. McGeamy. I think the key takeaways for this group is that, you know, folks who have been in care, who are active in treatment, are going to keep their services across April 1. You know, providers who have PAs in place are going to keep operating off of those PAs across April 1. And how the sausage kind of gets made behind the scenes, we can talk a little bit more about the mechanisms for that. And if billing teams, or if you have authorization teams, or you have, you know, clinical directors that have those types of requirements, we can be sure that providers understand how those things will effectuate. But we want to make sure that we're not, you know, bogging people down with too much information about how those services are administrated. I think Director Byrd had made that comment earlier today, you know, really with the beneficiary in mind. We want to ensure folks that they're going to, you know, things are going to seem very familiar to them, even though behind the scenes, you know, things are starting to change a little bit in how we reimburse and how we manage some of these benefits.
Thank you for that, Jennifer. I'm going to, next slide, please. I'm going to turn it back over to Director Byrd.
Thank you, Dr. Bazran. We just want to make sure folks are aware of a new learning opportunity through our continued technical assistance work under Integrated Care DC. You can see we are continuing our support of practice leaders navigating unfamiliar waters. So there's a Leadership Through Change Learning Collaborative that is coming up between February and May of this year. It's a combination of 6 to 8 virtual and in-person sessions. If you are interested, there's an application form. It is due next Friday, I think, February 2nd. You can access it through these slides. The slides will be sent out. They will be posted, and you can also go to the integratedcaredc.com website for that information. If you're not as familiar with Integrated Care DC, it is also the same entity that supported our managed care workshop back in May or June of 2023, but it's a technical assistance opportunity funded through the Departments of Healthcare Finance and Behavioral Health, and to really give you all additional support as we navigate all these changes. So I hope folks will take a look, and if you have any questions, you can reach out to Elizabeth Garrison here at the Department of Healthcare Finance. Slide.
Next slide, please.
We'll be back here on February 28th from 4 to 5 p.m. With updates and any other announcements and further discussion. Dr. Bazran, anything you'd like to say there?
No, I just like to say once again, Happy New Year. We're only 60 days about away from our transition date, and so we're going to keep pushing forward. It's been 2 years in the making, and I am really excited to see us begin to deal with whole person care and provide that to people we care about. So that's all I have. And Melissa, any final words?
What I've been saying for the past several months, Act Now, Stay Covered, as we continue through the first year of Medicaid renewals since the end of the continuous eligibility and enrollment through the public health emergency. You can go, beneficiaries can go to districtdirect.dc.gov or give us a call at 202-727-5355 with issues. Please act now so you stay covered and can keep access to all these services. That's it.
And so with that, have a wonderful rest of your day and week.
I did have one question. Not to keep
I
it
hear
long.
somebody. Yeah, Marie, you can have the last word. We're about to close.
I just wanted to, first of all, say thank you for the opportunity for the technical assistance. And I wanted to know if there's a limit for that.
Sure. And I probably should have said, Lisa, if you're online and can speak to the limit or any limits, that would be great. Otherwise, I'll follow up, Marie. Go ahead, Lisa.
Hi, I'm here.
Yes, at this point, there are no limits that I'm aware of. We'll do some small group cohorts. So, and the application is a quick 5 minutes to do. So I encourage anyone who's interested to join the Learning Collaborative. Thank you.
Thank you.
Okay, thank you once again. And on behalf of Director Byrd and I, have a great rest of your week. And we will conclude the session. Bye now.